We're going to get started on our first paper session. And we're lucky to have Dr. Nirav Pandya be our moderator. He's the Chief of Pediatric Orthopedics here at UCSF. Also, if you want to know anything about Bay Area sports or pediatric sports, please follow him on Twitter. So thank you.
All right, thank you, everyone. Today I'll be moderating the session on pediatrics and sports medicine. We have some great topics and presentations today. We'll do our series of presentations, then we'll open it up for a discussion. So please save your questions till after the discussion, and hopefully we'll have some great conversations about these presentations. Our first speaker will be Dr. Jennifer Lane from Gillette Children's. As many of you know, she is a UCSF alum, so we welcome her back. And her first presentation will be on does duration of non-weight bearing after femoral varus osteotomy affect outcomes at 2 years radiographically on patients with Perthes disease, an international multi-center study, prospective study.
Good morning. Thank you, Nirav, for the introduction. It's great to be back. Let's see. Here we are. So this study was funded in part by the Pediatric Orthopedic Society of North America. So as many of you know after grand rounds yesterday, Perthes disease is an idiopathic disruption of the blood supply to the pediatric femoral head. This leads to necrosis of cartilage and bone, and oftentimes leads to pain for about a year or two, and then the femoral head goes through this process of resorption and repair that leads to femoral head fragility and puts the hip at risk for deformity. And this deformity then puts the hip at risk for hip dysfunction and premature arthritis. So it's known that patients presenting with Perthes disease between their 8th and 11th birthday are known to have a poorer prognosis than their younger counterparts. And a femoral varus osteotomy is typically performed in the early stages of disease to try to contain the femoral head within the acetabulum. And the traditional postoperative regimen recommends 6 to 8 weeks of non-weight bearing to allow the osteotomy to heal. But it's also known that this period of fragility for the femoral head lasts longer than 6 to 8 weeks, and actually oftentimes is months. And it's also known through studies such as this weight-bearing MRI study that there is at least dynamic deformation of the femoral head with weight bearing. So therefore, some surgeons advocate a longer duration of non-weight bearing for Perthes patients after the osteotomy, such as 6 months or more. So the purpose of the study was to directly compare the 2-year radiographic outcome of patients who were treated with short non-weight bearing, meaning 6 to 8 weeks, versus long non-weight bearing, meaning 6 months or more, who underwent an early stage femoral varus osteotomy in this 8 to 11 age group. So this is a prospective IRB-approved study from the International Perthes Study Group, and we enrolled patients from 13 different centers and 4 different countries. All patients had the onset of Perthes disease between the ages of 8 to 11. They underwent a femoral varus osteotomy in the early stages of disease, meaning stage 1 or an early fragmentation. And all patients had a perfusion MRI showing at least 50% head involvement. And then whether they underwent short non-weight bearing versus long non-weight bearing was determined by the surgeon. So the primary outcome measure was a deformity index, which is a radiographic measure of the femoral head at 2-year follow-up. And this was performed by 2 independent observers. And the secondary outcome was the number of unplanned surgeries. So included in the analysis were 35 patients in the short non-weight bearing group and 40 patients in the long non-weight bearing group. And there was no significant difference between the groups with respect to sex, age at diagnosis, age or stage at osteotomy. But there was a significant difference statistically between the two with respect to the amount of hypoperfusion seen on perfusion MRI, though both groups were around 80% involved. As anticipated, there was a significant difference between the 2 groups with respect to duration of non-weight bearing, where the short non-weight bearing group averaged about 8 weeks of non-weight bearing, and the long non-weight bearing group averaged about 6.5 months. Interestingly, we found that both groups had a period of partial non-weight bearing that was about 4 to 4.5 months, and the short non-weight bearing group had an earlier return to full activity, which is about 1.5 years, versus the long non-weight bearing group returned to full activity at 1.9 years. So at 2-year follow-up, the deformity index was significantly lower, meaning less deformity, in the long non-weight bearing group with the short non-weight bearing group, where the long noun weight-bearing group had a deformity index of 0.30 and the short noun weight-bearing group had a deformity index of 0.38. And representative radiographs of what those deformity indices look like are shown here. Also, unplanned surgeries were noted to be higher at 2 years in the short noun weight-bearing group. There were limitations to this study. We only had 73% retention rate at 2 years, and compliance to noun weight-bearing could not be measured. We thought long and hard about how to measure this compliance and couldn't come up with a good solution. Also, the clinical significance of less deformity as measured by deformity index is somewhat unclear, although the literature has shown that a deformity index of higher than 0.3 is associated with the development of an aspherical head. The strengths are that this is an international multi-center study, and it also really kind of focused on a relatively small group of patients that were within a certain age range, had a certain stage of disease at intervention, and also had at least 50% involvement on MRI. Also, all of the radiographic measurements were made by blinded independent observers. In conclusion, the long noun weight-bearing group has significantly less deformity as measured radiographically compared to the short noun weight-bearing group following femoral varus osteotomy at 2-year follow-up with fewer unplanned surgeries. And this international multi-center prospective study is really the first of its kind to look at the effect of postoperative noun weight-bearing on the outcome after femoral varus osteotomy in this age group. Thank you.
Thank you. That's an excellent presentation. Next up, we have Dr. Tiffany Liu, one of our orthopedic residents here at UCSF, who will be talking about pediatric radial head ossification patterns.
All right. Hello, and on behalf of my co-authors, thank you for the opportunity to present our work on pediatric radial head ossification patterns. We have no disclosures. And so pediatric elbow radiographs can be difficult to interpret for various reasons. There are multiple ossification centers that come in at different ages, and the pattern of ossification can be different by gender. And moreover, ossification can happen eccentrically, as has been demonstrated in the capitellum. And so all of these reasons can make interpreting elbow alignment difficult. To our knowledge, there is no study that has looked at radial head ossification patterns. And so the purpose of our study was to define the pattern of radial head ossification at various ages of skeletal maturity using MRI. Secondarily, we sought to describe the offset between the ossification centers of the radial head and the capitellum, or the radiocapitellar offset on MRI. We retrospectively reviewed elbow and upper extremity MRIs completed at our institution between January 2011 and September 2022. We included patients who were 18 years of age or younger, and all MRIs were 1.5 Tesla or 3 Tesla. We excluded patients with deformity or trauma to the radial head, or if inadequate coronal and sagittal images were available. We determined radial head ossification as follows. We identified the true centers of the ossified radial head as well as the cartilaginous enlage by measuring the maximal anterior to posterior or radial to ulnar dimensions and then dividing these numbers in half. The offset between the ossific and cartilaginous centers were then calculated, and we reported these in percentages to control for variations in patient size. We reported radial and anterior offsets of the os relative to the cartilaginous portion as positive. And so, for example, in this example of an 8-year-old male, the radial head is the center of the radial head is denoted in blue, and the cartilaginous enlage is denoted by that orange dot. And so, on the sagittal image, the offset of the radial head ossification center is 2.5 millimeters posterior relative to the cartilage, and 1.2 millimeters radial in the coronal image. To measure radiocapitellar offset, we first determined the center of the ossified capitellum in a similar fashion. And for patients whose capitellum had fused to the distal humerus, the medial-most border was defined as the intersection between a line parallel to the humeral shaft and the apex of the ossified metaphysis. And this method has been previously described in Fader et al.'s 2014 study of capitellar ossification. The offset was then measured between the center of the ossified radial head and the ossified capitellum. So again, in this example, the radiocapitellar offset was measured as 3.6 millimeters radial in the coronal view, and there is no offset in this sagittal view. We included 66 patients in our study, 37 male and 29 female, and we were able to obtain at least one measurement in the coronal and sagittal views for each age and sex category, except for 4-year-old females. We found that the majority of ossification centers were eccentric in both the sagittal and coronal planes, so 67.6% in the sagittal plane and 71% were eccentric in the coronal plane. And of these patients who had eccentric ossification centers, the offset was more often posterior and radial. You can see that the magnitude of the offset in the sagittal plane was overall relatively small, and there was no statistically significant correlation between increasing age and the amount of offset in the sagittal plane. In the coronal plane, similarly, the overall magnitudes were relatively small, and there was statistically significant decreasing offset in the coronal plane with respect to increasing age. The magnitude of radiocapitellar offset in the sagittal plane was again overall small, with an average of 0.2% for males across all ages and negative 2.6% for females. However, there was no statistically significant correlation. In the coronal plane, the average radiocapitellar offset was larger, about 18% on average for both males and females. Again, no statistically significant correlation was found between the magnitude of offset and increasing age. In conclusion, this is the first study to our knowledge to describe the pattern of radial head ossification at various ages of skeletal maturity on MRI. We did find that the radial head ossification appears to occur in eccentric fashion, the majority of which is posterior and radial. We found that a radiocapitellar offset does persist to skeletal maturity, but the magnitude in the sagittal plane is overall small and smaller in comparison to the magnitude in the coronal plane. The limitations of this study include small sample size, and so future studies should seek to further increase the sample size in this patient population. And these are our references. Thank you.
Thank you, Dr. Liu. Next up, we'll have Dr. Dimitri, who is one of our UCSF residents as well, too, who will be talking about the clinical manifestations of constriction band syndrome.
Thank you for the opportunity to present our work today. I have no relevant disclosures. So you may be asking, what is constriction band syndrome? It is a rare constellation of congenital malformations that typically affect the extremities, so the hands and the feet. It has a highly variable clinical presentation, and currently there are no clear diagnostic criteria. Because of this, there's actually 34 different names to describe this syndrome. So if you've heard of Streeter's dysplasia or amniotic band syndrome, these are all actually referring to the same diagnosis. The etiology is unknown, but it is thought to be due to limb deformation that occurs in utero. So that means that the limbs initially begin forming normally, but subsequently become deformed or malformed later on in development. And this differentiates it from a failure of formation, where a limb or a digit fails to form in the first place. And because the etiology is unknown, it is unclear which patients are most at risk for developing this condition. So the objectives of our study were twofold. First, we sought to characterize the clinical manifestations of constriction band syndrome. And using this information, we proposed diagnostic criteria to standardize the diagnosis of constriction band syndrome. And second, we sought to assess possible demographic and prenatal risk factors for constriction band syndrome. This was a retrospective review of children presenting to our tertiary pediatric medical center from 1998 to 2018, and patients were identified using ICD-9 and ICD-10 codes. We reviewed medical records, clinical photographs, and radiographs to characterize limb involvement. And we compared patient characteristics to statewide newborn population averages to evaluate for potential risk factors. In terms of our results, we identified 128 children with constriction band syndrome. The most common features were constriction bands, seen in 96% of patients, digit or limb amputations, seen in 88% of patients, and acrosyndactyly or non-adjacent syndactyly seen in 69% of patients. Acrosyndactyly is when you have fusion of digits distally with a proximal sinus, suggesting that the fingers or the digits fuse or develops normally initially and fuse at a later point in development. And similarly, non-adjacent syndactyly is when two digits that are not next to each other, such as an index finger and a ring finger, fuse distally, again, later on in development. So when comparing these common features of constriction band syndrome to features seen in other congenital conditions, we found that constriction bands in acrosyndactyly or non-adjacent syndactyly are unique to constriction band syndrome. They're not seen in other diagnoses. So these were considered pathognomonic findings of constriction band syndrome. But digit or limb amputation can be confused with a failure of formation where a digit or a limb never forms in the first place. So looking at our population a little bit closer, we found that one of the common findings is bony overgrowth in this population. So in an amputated limb or digit, the bone can continue growing as the child grows, and sometimes that necessitates a revision amputation surgery. And this is similar to the phenomenon that's seen in an acquired amputation. When a child undergoes an amputation during childhood, similarly, the bone may continue to grow. But this is not seen in a failure of formation diagnosis. So this differentiates it and is then considered a pathognomonic finding for constriction band syndrome. And additionally, we found that bones proximal to the amputation level are normal in all cases seen in our population. And again, this is different than what we see in failures of formation, where the proximal bones are often abnormal appearance. So putting this all together, we proposed these diagnostic criteria, the first of which was if there's more than one or more pathognomonic finding of constriction bands, acrosyndactyly or non-adjacent syndactyly, or bony overgrowth. And number two, the bones proximal to the congenital amputation must be normal. In terms of other notable patterns we found in this population, the first is that most features were limited to the distal extremities, so the hands and the feet. We also found a strong predilection for involvement of the central digits, with relative sparing of the thumb and the small finger, as well as the big toe and the small toe. And finally, we found that children who had one or more associated diagnoses, such as clubfoot or cleft palate, had more limbs affected by constriction band syndrome, whereas children who were otherwise healthy had relative sparing of their limbs or lesser involvement. And so this suggests we could categorize constriction band syndrome into either a more mild or more extensive phenotype. In terms of demographics and prenatal risk factors, we compared to population averages, children with constriction band was associated with young or old maternal age, low socioeconomic status, prematurity, and low birth weight. So in conclusion, constriction band syndrome can be distinguished from other congenital anomalies based on the pathognomonic findings and proposed diagnostic criteria. Constriction band syndrome could be categorized as having either a mild or extensive involvement. And low socioeconomic status and related prenatal risk factors, including prematurity, low birth weight, and young maternal age, may predispose children to the development of constriction band syndrome. Future research should focus on clarifying the role and mechanisms of these risk factors. Thank you to Shriners Hospital, Northern California, where this study took place, as well as my co-authors.
Thank you, Dr. Dimitri. And we're going to bring up Dr. Lane again, who will be talking about delay in diagnosis of Love-Carpathy disease in the young child.
Thank you. I'd like to acknowledge my co-authors and again, the International Perthes Study Group. So I'm switching gears here a little bit, still talking about Perthes, but now a younger age group. And also this study is again partially funded by grants from the Pediatric Orthopedic Society of North America, as well as partially funded from the Gillette Children's Foundation and Scottish Rite for Children. So just to use a case to demonstrate what I'll be talking about today, I want you to take off your orthopedist hat for a second and instead put yourself in the shoes of a parent of a 4-year-old boy. Okay? You notice that he is starting to limp, and he seems to be pointing to his thigh and his knee, and you don't really remember a specific injury, but he's pretty active and he falls like it's his job, like most 4-year-olds do. And so, it's a Saturday, you decide you should probably take him in to get checked out. Can't get into the pediatrician's office, so you go to urgent care. And they tell you that it's important to rule out musculoskeletal infections, so they run a battery of tests, including inflammatory markers, and if you're in Minnesota, they test for Lyme. And also, you want to rule out injuries, so you get a knee x-ray, which is red as normal. And so they're told, it doesn't look like anything acute. If it doesn't go away, go see your pediatrician. So give it a couple weeks, so your child is still limping, they're still pointing to their knee, and so you take the morning off from work, and you go to see your pediatrician, and they run the battery of tests again, and again, they're normal. And this time, they do get a pelvis radiograph, but the radiologist reads it as normal. And so the pediatrician says, I'm not sure what this is. Maybe it's growing pains. Just give it some time, okay? So you let your child go back to those regular activities. You encourage them, despite their limping, to go play soccer, burn off some energy on your trampoline. Some of your friends' parents are saying, your kid's limping. And you say, well, I've seen 2 providers now, and they tell me it's fine. But after, a few months, they're still limping. So you call your pediatrician, and they say, okay, well, why don't you go see an orthopedist? I'm not sure what's wrong. So you go in to see the orthopedist, and they repeat that pelvis radiograph, and now you see a hip that looks like this. So you see a fairly sclerotic femoral head that's pretty flattened. You see metaphyseal cyst and a little bit of extrusion. So the orthopedist tells you that your child has Perthes disease, and your child's pretty young, they're 4, so they say, well, there's really not much treatment we recommend, except don't do anything like sign him up for soccer, don't let him use a trampoline, and really limit their running and jumping. So as a parent, you're pretty frustrated because you've had multiple touch points with the medical system over the last few months, and you've been letting your kid do exactly what you shouldn't be letting your kid do. So with Perthes disease, typically kids present with limp and oftentimes pain. And the traditional literature suggests that the average age group is about 4 to 8 years of age at diagnosis, although oftentimes classical teachings are that this is kind of a school-aged condition. But both anecdotal experience and recent literature suggests that maybe this age group is shifting a little bit, and that actually the age group that has the highest incidence is this 2 to 5 year age group. And this is a recent Kaiser database study that showed that over 60% of the new cases of Perthes were between ages 2 and 5 years. So since this contrasts the classic teaching, this may lead to a delay in diagnosis or unnecessary investigations, such as knee radiographs and a number of lab tests. And then also, is Perthes even in the differential diagnosis for providers that are seeing some of these really young patients? So the purpose of the study was to identify factors that may indicate delayed diagnosis of Perthes disease in young children, meaning diagnosis at age 5 or younger. And so again, this is a study out of the International Perthes Study Group. This is a prospective, multi-center international registry of young patients presenting with Perthes disease. And we included unilateral cases of Perthes disease diagnosed by X-ray at less than 6 years of age. We identified 226 patients from 28 different centers. 82% were male, which is consistent with the literature. And within this cohort, the average age of diagnosis was about 4.4. We found that over 40% were diagnosed in the late stages of disease, which is known to be a time where treatments are less effective. And also, on average, patients and families sought care or opinion from about 3 providers before obtaining their definitive orthopedic care. And most often, these are primary care physicians or ED physicians. On average, it took about 3 months of symptoms until patients were diagnosed, but about 35% of patients had at least 6 months of symptoms before diagnosis. 69% of patients reported having pain, but it was noted that if the pain localized to the hip or groin, that they were diagnosed earlier. And if they had referred pain to the thigh, to the knee, or had a combination of symptoms, that it took a significantly longer time to be diagnosed. So in conclusion, a delay in Perthes diagnosis for young children is common, and about 40% are presenting in the late stages of disease, and there's a significantly longer duration of symptoms until diagnosis if they have referred pain to the thigh or the knee. And the significance of this is that it may result in significant familial distress. And you can think about the financial burden, the time burden, and the emotional burden of this. And also there may be an impact on delayed diagnosis to the patient. Again, we may be missing that window of treatment. So it's clear to us that we need improved educational efforts. And since patients are oftentimes seeking care for this limb from their primary care physician or their ED physician, I think that that's really our target population for education. Thank you.
Awesome. Thank you again, Dr. Lane. We're going to open it up for questions. We have about 5 minutes for questions. Just while everyone's walking up, first question for Dr. Lane on your first study. Although there were radiographic differences, how did you see, this manifesting clinically for a lot of patients? And based on how that manifests clinically, is it changing your practice?
Yes. Okay. So thank you for that question. I think it's the necessary question from this study where we did have a statistically significant finding radiographically, but what does that really mean clinically? And I think we don't know. What I would say is I think of this study as a preview study. For those of us that treat Perthes disease, the story is not over at 2 years, right? You have a much better sense of how this hip is going to do at 5 years or its skeletal maturity. And so hopefully in 3 years I can be back discussing the 5-year outcome. But I'd say that in my practice, I'm in the short non-weight-bearing group, and this is not definitive enough of a finding or a difference for me to change my practice. Because I think another thing we need to be asking is what is the impact on quality of life with prolonged non-weight bearing on patients and families?
This is a question for Dr. Lane. Congratulations for doing an international randomized control study. That's quite an undertaking. And you had very clearly defined primary endpoints, and it sounded like you did an intent to treat analysis. Is that correct? The reason why I'm asking is I'm just curious to know about the compliance rates of these individuals, and the compliance for non-weight bearing can be different depending on the socioeconomic group, and I'm just wondering if the compliance actually made the difference or not.
We have not yet done an intent to treat analysis. Basically, each surgeon chose to commit to a treatment pathway. We have strong enough preferences in the group, and orthopedists tend to be somewhat opinionated, that the surgeons were not willing to commit to randomization between these two different courses. And so, for instance, I recommend the same non-weight-bearing regimen for all of my patients that are in this study. No matter, well, at least that's my recommendation. So we do have limitations in study design, and we haven't yet done the intent to treat analysis. With respect to compliance with non-weight bearing, I think that's really hard to measure, and we thought about putting accelerometers on crutches or putting a pressure sensor in their shoe. But I mean, these kids, if they want to go run around, they'll just take that shoe and throw it in the closet, and it's not registering any pressure. And so really this is just kind of what has been recommended, and also what the parents and children are reporting their compliance is. I would say one last thing, just clinically, you can kind of tell who's weight bearing and who isn't if they have a really atrophied leg, and when you ask them to move around the clinic room and they really hop around pretty comfortably on one leg, or if you notice that they just walk to the examining table, if they walk pretty comfortably, that's not a patient that's been non-weight bearing regularly.
Dr. Berman.
Yeah, thanks to all three of you for great papers, and I'm going to diversify the questions a little bit to Leah. But Jen, I do want to say congratulations on the body of work you're putting together, and doing the work in your leadership in the international group is fantastic. So I'll ask you later about social determinants of health, but in the interest of spreading questions around, Leah, great work on classifying constriction band syndrome. And classifications are so important in terms of understanding natural history and guiding treatment. So where do you think that this is going to help us with regard to understanding either natural history or knowing maybe some algorithms where to go with treatment?
Thanks for your question, Dr. Bourbon. So I think We talked about the mild versus the more extensive phenotype and associated diagnoses. So one of our other findings was that children who had this more extensive phenotype definitely underwent more surgeries than children who had the more mild phenotype. And so I think that's really important in terms of counseling families when they're coming into clinic. So some of the surgeries, either a revision amputation or separating an acrosyndactyly. So giving the families a sense of what they can expect over the years coming, of what their children might experience, is one useful point of having a classification like that.
Dr. Westreich.
Thank you. Great papers, everyone. This is for Dr. Liu. So that was a really interesting study, and I just want to know, how do you plan to translate all the information from your study to the clinical practice?
Yeah, thank you for that, Dr. Westreich. I think, especially having gone through training, being very near to, just a few years ago, taking Mission Bay call and pediatric call for the first time, seeing elbow radiographs for the first time can be very intimidating, right? Because of the different ossification centers, and judging appropriate alignment when someone is calling you for elbow pain in a young patient. I think this study can help reassure us that, even though the radial head does come in eccentrically, that's something to keep in mind when you're looking, at coronal radiographs, but the magnitude in the sagittal plane is quite small. And so I think we still can use, what we typically use in terms of radiocapitellar alignment to judge whether or not this patient should be immobilized or needs further workup.
Great. Well, I wanted to thank our first group of speakers for their presentations, and we'll move on to the next session. Thank you. So now we're going to be moving on to the sports medicine shoulder section for presentations. And our first speaker is UCSF resident, Dr. Charles Kogan, who'll be talking about effect of obesity on short and long-term complications of shoulder arthroplasty.
All right. Hello, everybody. First of all, I'd like to thank my co-authors. Many of you are in the room today. We'll be talking about the effect of obesity on outcomes in shoulder arthroplasty. No relevant disclosures. Glenohumeral arthritis is common. It's estimated to affect about 17% of the adult population, and we've all seen these patients in our clinics. We do know that total shoulder, anatomic and reverse total shoulders are an effective treatment, but they're not without complication either. Similarly, obesity is even more common. So currently estimated to affect about 42% of the population, and we know that that number continues to rise every year. This has been studied before, looking at the effect of obesity on complications after total shoulders, but the results are inconclusive. So the point of this study was to ask the question, what is the effect of obesity on short and long-term complications of total shoulder arthroplasty? So this is a Pearl Diver study. It's an administrative claims-based database, and this was looking at the years from 2010 to 2020, and this was a matched cohort study. We looked at all the patients during those years who had total shoulder arthroplasty, both anatomic and reverse, and we were able to look at them and further stratify them by preoperative and postoperative diagnoses. So we looked at medical complications. These included things like readmissions, MI, VTE, surgical site infections, short-term PJI, as well as surgical complications and revision surgery. So looking at things like periprosthetic fractures, acromial stress fractures, dislocation, and again, prosthetic joint infection. Additionally, using ICD-10 codes, you're able to stratify these patients by obesity. So we could look at them anywhere from not being obese, BMI less than 30, obesity 30 to 40, morbid obesity 40 to 50, and then a newer classification that you may be hearing of, super obesity, and that's BMI greater than 50. So here's a consort diagram. Initially we had 164,000 patients. We did exclude quite a few for various reasons, including diagnoses like infections, prior fractures, lack of established follow-up in the database, and then as well as non-specific BMI codes. So again, the codes we were using were allowing us to specifically stratify based on BMI. There are also codes out there that are just blanket statement obesity, We excluded those patients because it didn't allow us the granularity to draw some of the conclusions that we were looking for. So ultimately, we had 86,000 patients, nearly 87,000 patients with 90-day follow-up and almost 54,000 patients with 2-year follow-up. You can see here mean age ranged from 62 to 69. In the pre-match comparison, looking at patients with BMI greater than 30 compared to patients with a BMI less than 30, you can see the patients tended to be younger, they tended to be female, smokers, and diabetics. After we matched for variables sex, age, diabetes, smoking, and Charlson Comorbidity Index, there were no differences between the two groups. On the right here, you can see incidence of shoulder arthroplasty over time. You can see, I think what's most notable is that the group of patients with obesity continues to increase. So here are results. This is first the unmatched cohort analysis, and busy slide, but I draw your attention to the red arrows, which basically show an increase in incidence for all of the medical complications is at 90 days after surgery. You can see increased rates of various things like readmission, VTE, superficial infection, prosthetic joint infection. You can also see that as BMI goes up, these complications increase in incidence. Here's the matched cohort analysis, and this is looking at now odds ratios. And you can see very similar trends, same things that are an increased risk of these medical complications listed in red if you have obesity. And again, the odds go up as BMI goes up. Here are the surgical complications. This is, again, unmatched cohort analysis, so this is the incidence. You can see things like dislocation, prosthetic joint infection, and revision surgery do all go up. However, when we did the matched analysis, these were not statistically significant. And again, the matched analysis is really isolating obesity as a causal risk factor, as opposed to things that might be confounding, such as a lot of patients who are obese often have diabetes. And in this rate, you can see that prosthetic joint infection was really the only significant difference. Mechanical complications were not increased in the obese group. So in conclusion, we know that the rate of patients undergoing total shoulder arthroplasty with obesity is increasing. We see that medical complication and infection are greater in obese patients undergoing total shoulder at 90 days after surgery, even when matching for age, sex, diabetes, smoking, and Charlson Comorbidity Index. But obesity is not an independent risk factor for mechanical surgical complications or revision surgery at 2 years. As a Pearl Diver study, this of course is subject to some limitations such as reliance upon accurate coding of ICD and ICD 910 and CPT codes, which is very important to state. Thank you.
Thank you, Dr. Kogan. Our next up will be Dr. Ryan Freshman, who's one of our residents as well, too, who will be talking about delayed arthroscopic management of FAI, increases rates of revision surgery, and postoperative narcotic prescriptions.
Thanks for the opportunity to speak here today. We have our disclosures, none of which are relevant to this talk. So the question of surgical timing frequently comes up in sports medicine clinic with patients often asking, what happens if I wait for my surgery, or am I doing something worse to my body by putting this procedure off? And while delayed management of some knee and shoulder injuries was previously thought to be benign, several recent studies have demonstrated that patients presenting in either a delayed fashion or with more chronic injuries can have additional associated pathology and or worse postoperative outcomes, thus highlighting the importance of timely surgery. These studies on early versus delayed ACL reconstruction have reported higher rates of irreparable meniscus tears, chondral lesions, and pain in patients undergoing delayed surgery, while other studies on rotator cuff repair showed higher rates of revision surgery in patients undergoing delayed surgery as compared to those who underwent early surgery. However, the relationship between surgical timing and outcomes is less well defined in hip arthroscopy, and the optimal timing of hip arthroscopy for femoroacetabular impingement syndrome, or FAIS, is less clear, which leaves room for debate over whether to perform surgery earlier to attempt to slow the progression of chondrolabral damage or to continue with non-operative measures over a longer term. While patient-reported outcome measures have been shown to be worse for patients who either delay hip arthroscopy for greater than 6 months or for those patients with chronic pain, these studies are underpowered to reach conclusions about how surgical timing affects the risks of revision hip procedures and conversion to total hip arthroplasty, and have not examined the relationship between surgical timing and postoperative pain or narcotic use. So the purpose of this study was to examine the relationship between the timing of hip arthroscopy for FAIS and rates of postoperative medical complications, revision hip procedures, and opioid prescriptions in a large cross-sectional cohort. And we hypothesized that as the time from diagnosis to surgery increases, patients will undergo higher rates of 2-year revision hip arthroscopy and conversion total hip arthroplasty, as well as higher rates of postoperative narcotic prescriptions. And so to do this, we performed a retrospective study using the Pearl Diver database, using ICD-10 and CPT codes to stratify patients based on time from diagnosis of FAIS to hip arthroscopy. And these cohorts were further divided into 3-month intervals ranging from under 3 months from diagnosis to surgery to over 12 months, and all patients had a minimum of 2-year follow-up data available. After the univariate analysis, we performed multivariate analysis looking at which of these risk factors were independently associated with an increase of revision procedures, and constructed Kaplan-Meier curves to look at both time to revision hip arthroscopy and conversion total hip free survival. And then odds ratios, 95% confidence intervals were calculated, and significance was set at less than 0.05. So within the cohort, we had about 6,700 patients, 80% of which who had surgery within approximately 3 months of their diagnosis. And we saw that the patients who underwent surgery earlier tended to be slightly older, yet healthier, but on CCI than those who underwent surgery later. And interestingly, preoperative opioid use was relatively high in the bottom row there amongst groups, although this is fairly consistent with what's reported in the literature for patients with FAIS. Also looking at 90-day complications and readmissions, there were slight differences in rates of 90-day readmissions and wound infections between patients, but overall, I would say no clear trends when looking at this data. Additionally, the rate of conversion to total hip arthroplasty within 2 years was also not significant between groups. However, there was a clear trend when looking at rates of revision procedures and narcotic prescriptions between patients. And while the overall 2-year revision hip arthroscopy rate was around 10%. You can see that revision rates climbed significantly as time to surgery increased and approached almost 50% in patients who underwent surgery over 12 months after their original diagnosis. And there was also a similar trend in opioid prescriptions filled within the first 90 days after surgery. And so when controlling for the demographic variables above, as well as time to surgery in a multivariate regression analysis, there was a direct relationship between time to surgery and risk of revision surgery. And when you saw the odds started to increase for all procedures at about 6 months, but if you substratify this by revision procedures such as labral repair or revision femoroplasty, you saw that this difference may even begin as soon as 3 months, 3 to 6 months wait. The Kaplan-Meier analysis demonstrated significant differences in revision hip arthroscopy-free survival between cohorts. At about 200 days post-op, there was an inflection point where survivorship declined in those patients who had 6 months or longer from their original diagnosis to surgery. However, there was no such difference seen in survival for conversion total hip arthroplasty over the same time period. So in conclusion, we observed that delaying surgery for hip impingement as little as 6 months can increase the risk of undergoing revision hip arthroscopy, negatively influences revision-free survival, and affects rates of filling post-operative narcotic prescriptions between patients. However, the timing of surgery did not appear to affect 90-day readmissions or complication rates with a significant trend or affect conversion to total hip arthroplasty. And while our results are likely multifactorial, we speculate that they can be related to continued chondrolabral damage that occurs over time in patients who delay surgery, with resulting poor tissue quality or irreparable pathology that happens over time, which then makes them more prone to failing a primary surgery or developing chronic pain. We had some limitations in our study, similar to Charlie's study, retrospective design that was reliant upon ICD-10 and CPT coding, no access to patient-reported outcome measures and or MRIs or operative reports. But I'd say the overall message I'd like to give is that timing is definitely something to consider when you're counseling patients with hip impingement, as the chronicity of their symptoms may actually affect their surgical outcomes after hip arthroscopy. And I'd just like to acknowledge my co-authors and thank you very much.
Thank you, Dr. Freshman. Next up, we'll have Dr. Garcia Lopez, one of our residents as well, too. We'll be talking about high rates of conversion to total hip arthroplasty after core decompression for avascular necrosis.
Thank you for the introduction. I'd like to acknowledge my co-authors and thank everyone for the opportunity to present our work today. Disclosures for all authors are updated regularly, none irrelevant for this talk. Avascular necrosis of the hip is caused by interruption of blood flow to the femoral head, resulting in pain, loss of function, and eventually hip arthritis that needs a total hip arthroplasty. AVN accounts for 5 to 12% of all total hips performed in the US. There may be many risk factors for the disease, the most common being corticosteroid use, followed by alcohol use, which combined make up 70% of all cases of AVN. Management is largely dictated by AVN stage, patient age, and comorbidities, core decompression being an option for early stage AVN. The goal of core decompression is to reduce intraosseous pressure and restore normal vascular flow by drilling multiple holes into the femoral neck and head. Given the relatively rare nature of AVN, reported effectiveness of core decompression and complication rates are inconsistent in the literature and based on small sample sizes. In addition, predictors of conversion to total hip after core decompression are not well defined. Thus, the purpose of this study is to 1, determine rate of conversion to total hip after core decompression, assess predictors of early conversion to total hip, and 3, examine complications after hip core decompression. For this study, we queried data from the M91 ortho data set of 91 million insured patients with CPT codes for core decompression and subsequent total hip arthroplasty. Patient demographics were evaluated as possible predictors of early conversion to total hip. ICD codes were used to identify adverse events within 90 days after core decompression. Between 2010 and 2020, 555 patients were identified who underwent hip core decompression. Within 2 years of core decompression, 40% of patients converted to total hip. Cox survival plot on the right demonstrated a high risk of conversion to total hip within 2 years of core decompression, with the highest risk being within the first 200 days. Age was the only statistically significant risk factor for conversion to total hip. Other demographic variables such as sex, steroid use were not significant predictors of conversion to total hip arthroplasty. The largest proportion of patients who converted to total hip were between the ages of 40 and 59, as seen in the bar plot that demonstrates those that converted to total hip versus those that did not by age category. The 90-day complication rate was 2.9%. The most common complication was femoral neck fracture. No cases of HO or postoperative infection were identified. Demographic variables were similarly not significant predictors of complications. In this study, nearly 40% of patients who underwent hip core decompression converted to total hip at 24 months. Rate of conversion is higher, and time to conversion is faster than has been previously described in the literature. Age was the only statistically significant variable in terms of conversion to total hip. It is possible that surgeons may be more willing to offer total hip to an older patient with ongoing symptoms after core decompression, whereas younger patients may be counseled to avoid early conversion. For this reason, patients over the age of 40 with AVN should be carefully counseled about their options. We found a relatively low complication rate at 90 days, suggesting that cord decompression is a safe procedure for the treatment of AVN, with the caveat being that there is a risk of femoral neck fractures. This study is not without limitations. We relied on the accuracy of ICD and CPT coding, and we were unable to determine FECOT staging given the ICD limitations again. Additionally, there are variables that we did not assess that may better predict conversion to total hip after cord decompression, and we did not assess patient-reported outcomes in the study. In conclusion, there is a high failure rate following cord decompression for hip AVN, with 40% of patients converting to total hip within 2 years. While the overall complication is low, patients should be counseled regarding the risk of femoral neck fractures. Thank you.
All right, thank you. Next up, we have Dr. Stephen Barad from Sacramento, who will be giving a talk on acromial and acromial spine fractures after reverse total shoulder replacement, prosthesis type, diagnosis, and treatment.
It's certainly an honor to be here at this great program where I started my career in orthopedics about 43 years ago, and I do feel old. This is let's see, how do we move this? Okay, no disclosures, although I wish I had a few. Sorry about that. I'm not sure what that line is. In the mid-'80s, Dr. Paul Gramont, I developed this type of prosthesis, which really helped a lot of people with cuff tear arthropathy. It was introduced in Europe in the mid-'90s and the United States in 2001. About 3 or 4 years after that, I started doing a few. And so as my arthroplasty practice started expanding, I started seeing more of this complication, which was postoperative fractures. And I was concerned that this was somehow due to my exclusive use of what is called a Paul Gramont prosthesis, basically relying on a distalized center of rotation, which improved the lever arm. The humeral component is directly beneath this. This improved forward flexion, but my concern was I causing something by exclusively using this type of a component with few exceptions. So I queried our Dignity Health database in Sacramento and looked for surgeons that actually performed reverse total shoulder replacements and those that had this postoperative complication. And interestingly, those with not really great volumes didn't even know or weren't even aware that this type of a complication existed. My concern was occurrence with this type of prosthesis and other kinds of prosthesis. Was this something solely due to the Gramont style? I looked at age, time of surgery, location of the fracture, and the method of treatment, whether it be open reduction internal fixation or simply immobilization. And then I created this very unscientific outcome analysis, poor, satisfactory, good, poor being they had pseudoparalysis even after our treatment, good, they were able to gain some type of forward function, which was which was certainly an improvement from their state previously. Now, in clinical practice, we know there are only two real outcomes that matter. The patient's either happy or they're unhappy. So let's take a second to look at various implant designs. To the left, we have the Gramont style prosthesis, the center of rotation right on the glenoid face, and then you have the pivot point on the humeral prosthesis with minimal displacement laterally. If you look at the second one, you can lateralize the glenosphere by increasing or changing the shape of it or placing a bone dowel behind the metaglean interfacing with the glenoid face. This is popularized by Dr. Pascal Below. To the third one, you can keep a medial center of rotation, but lateralize the humeral shaft. And you do this usually with platform prosthesis. And then at the last, you have the combination of both. Now, for a lateralized glenosphere, usually the tide mark is about 5 millimeters, and for a humerus, it is greater than 15 millimeters. being greater is lateralized, being lesser is considered medialized. Does this make a difference? Well, you see the direct vertical translation of force on the acromion versus the more lateral construct, lateral, a more tangential force. These are Crosby type classifications. There's a few different kinds, Levy and various others in the literature, but this is what I used. Type 1 is basically an anterior acromion injury. Type 2 involves the angle as well as the spine and base, and type 3, the spinous process itself. Nothing ruins a great surgery as quickly as a postoperative fracture. You do this great surgery, you have a beautiful x-ray, you want to show everybody in the hospital what a great job you did with the radiograph. Patients are ecstatic, and then something happens. Doc, I was doing great, I lifted something, and something popped or happened in my shoulder, and now they're in severe pain, and they cannot move their arm. X-rays are often normal, so it requires a high degree of suspicion, and in this case, a CT scan is extremely helpful. Here we have a radiograph. You see all the bony detail more or less obscured by the scapula, the lungs, the spine of the scapula itself, whereas a CT scan to the left is very important in diagnosing a scapular base fracture at the base of the spine, as you can see here. If you catch these early, they have a great chance of healing. This is a minimally displaced acromial fracture, a type 1, I would say, and the PA view afterwards, after the open reduction internal fixation. Sometimes you don't need a CT scan. The X-rays show you everything right here. A lateralized gonosphere with a medial humeral component and the postoperative X-rays. So what do we find? In the query I did over a period of about 5 years or so, we identified about 20 fractures. The average age, about 74 and a half. Time to injury, 9 months. And if you look at fracture type, we had 13 type 1, 5 type 2, and 3 type 2 fractures in that category. What about configuration and relevance in that regard, which was really the initial query and my concern? Was it this only due to a Grammont style? In the medial, we were able to tabulate about 182 cases. This is my series, as well as someone from the university, and we had 7 fractures with a rate of about 3.8%. With the medial lateral configuration, we had about 3.4%, which is pretty much similar. Lateral medial, we accumulated 4 fractures, but I did not have the number of procedures performed, as most of these were referred, but we identified 2 fractures in the lateral configuration. So you can see it happens with all types. If you look at the literature, somewhere between 0.6 to 15%, depending on what article you read. It's not that uncommon, unfortunately. If I look at fracture type and compare it to the type of prosthesis, it's more or less all over the board here, and not confined just to the medial configuration. Treatment. We had 10 people in the open reduction internal fixation group and 10 in the non-operative category, where they were treated with an abduction brace and perhaps a bone stimulator. If they healed, they did great. If they didn't heal, they didn't do great. This is really a simple surgery. So for me to pull the trigger, particularly with something I can get to relatively easy, I typically do it to not lose range of motion and keep their function as optimal as possible. Clean out the fracture site, bone graft the heck out of it, and then place a reconstruction plate atop this. This is that very patient about 2.5 weeks after his surgery to remove his staples. Although I don't condone early range of motion, he was very happy with his outcome. And you can see his brace in the lower left-hand side of the picture there. Typically, I start passive range of motion only, keep their motion, and then active, not for at least 6 to 8 weeks. So in conclusions, these type of injuries can occur with all prosthetic configurations. Fracture union, regardless of either treatment, was associated with a good result, non-union with a bad result. And in my experience, even though they were doing great and you were improved after the treatment if they healed, they were never as good as they were prior to the incident. And The thing I learned over the last several years, the possibility of this injury occurring is really part of my informed consent. And finally, this unrecognizable picture of myself was about 40 years ago. This is at the Bones Ball. It was a big night for me. My beautiful wife, Beverly, of 40 years, was with me, and in the middle was our chairman, Dr. William Murray, at the time. It was a big night, and I know tomorrow night is a big night for many of you out there. I wish you nothing but the best success and happiness and a fulfillment as you move forward in the next stage of your life. Congratulations, all of you. Thank you.
Great, thank you, Dr. Barad. And our last presenter for the morning will be Dr. Fabian Su, one of our residents as well too, who will be talking about outcomes and risk factors of acromial stress fractures after reverse shoulder arthroplasty as well. Thank you.
Thank you, Dr. Barad, for that perfect segue into my talk. I'd like to thank all of my co-authors for contributing to this study. These are our disclosures, none of which are relevant to this talk. So acromial stress fractures are an uncommon injury after reverse total shoulder arthroplasty. The incidence ranges in the literature, but overall, it's on average, it's about 3.9%. These injuries are devastating to the patient as they disrupt the deltoid tension, resulting in a severe loss of shoulder function. There are multiple factors that have been described in the literature, both implant and patient-specific. So factors that affect the structural integrity of the bone, such as osteoporosis in female sex, can increase the risk. And then implant design choices, such as increased lateralization of the glenoid or the humeral stem, can also increase this risk. In the literature, there is limited evidence to guide the treatment of these fractures, as there are few studies comparing non-operative to operative fixation. And regardless of treatment, these patients with acromial stress fractures do worse and compared to patients who did not sustain a fracture. So understanding the risk factors and treatment outcomes of this type of injury is critical, as surgeons may modify their implant choices. They may avoid lateralizing, or they may change their postoperative protocol. And these fractures are extremely difficult to treat with high non-union rates, so prevention is key. Therefore, the goal of our study was twofold. First, it was to determine the risk factors for the occurrence of acromial stress fractures. And second, it was to determine the surgical complications and revision rates of conservatively and operatively managed fractures. So this was a study using the Pearl Diver database from 2010 to 2020. We used ICD and CPT codes to identify patients with a minimum of 2-year follow-up. After our exclusion, we were able to identify 3 cohorts, patients who had a fracture that underwent non-operative treatment, patient with fractures who underwent surgical fixation, and patients without any fractures. We also looked at their comorbidities using ICD codes. We also looked into the Mariner drug prescription database to see what type of medications were these patients taking before surgery, such as oral corticosteroids and osteoporotic medications, including anti-resorptives and teriparatide. Steroids were further broken down into whether or not the patient was using these chronically or whether or not it was a one-time use within 3 months of surgery. We also looked to see whether or not a preoperative corticosteroid injection within 3 months before surgery increased this risk. To avoid misclassification with injections into other large joints such as the hip and knee, we verified that the ICD codes were associated with shoulder pathology. Lastly, we took a look to see whether or not physical therapy within 6 weeks of surgery was also a risk factor. These complications and revisions were then tracked for 2 years after the reverse total shoulder arthroplasty index procedure or the diagnosis of an acromial stress fracture or after surgical fixation. We did effect modification analysis for various subgroups, and then we also did a multivariate logistic regression to identify the independent predictors. Multiplicative interaction was also assessed between the predictors. So overall, in this cohort, there was an incidence of 1.4% occurring at a mean time of 1.4 years after surgery. Female sex, osteoporosis, rheumatologic disease, as well as chronic lung disease were all associated with an increased risk of fracture. Looking at medication use, we can see that patients who were chronically on steroids had an increased risk of fracture, whereas one-time use within 3 months before surgery did not increase this risk. Injections and anti-resorptive medications, as well as early physical therapy, were all associated with an increased risk of fracture. On subgroup analysis, we found that among patients with osteoporosis, early physical therapy increased the risk by 71%. However, among patients without osteoporosis, this risk was not significant. On multivariate analysis, we found similar results. Other covariates that were previously described in the literature were not significant predictors. Among our patients with acromial stress fractures, the overall surgical fixation rate was 8.6% at a 3.6 months after the diagnosis of the fracture. Patients that underwent ORIF had higher rates of infection, component loosening, as well as subsequent revision reverse total shoulder arthroplasty. So in summary, I want the audience to take away that there are 5 risk factors that were described in our study that increase the risk by at least 50%. These are osteoporosis, rheumatologic disease, chronic steroid use, as well as injection within 3 months of surgery. And among patients with osteoporosis, early physical rehabilitation can also increase this risk. We hypothesized that early PT may place excess stress on the acromion in patients with already compromised bone. We also found that 27.8% of patients with osteoporosis received some form of medication to treat it before surgery. And then anti-resorptive therapy did not reduce the risk of acromial stress fractures, but actually increased it. However, this may be due to the fact that treated patients were more likely to have lower bone mineral density. Regarding surgical fixation, we found that it had higher rates of complications after surgery. The need for a second incision, lack of soft tissue coverage, and high rates of hardware removal are possible explanations to why the infection rate is higher. And then regarding instability and component loosening, most of these fractures that undergo fixation are more medially based. As Dr. Barad mentioned, these are usually the Crosby 2s or 3s. And then over 50% of these go on to non-union. So our hypothesis is that there may be a greater loss of deltoid tension with more medial based fractures, and then that there may be scapular notching due to protraction of the scapula with loss of deltoid tension. There are several limitations to this study. As everyone here has mentioned, the accuracy of the CPT and ICD codes determines the accuracy of our data. We also did not have any information on prosthesis design, so the effect of lateralization, onlay or inlay stems cannot be adjusted for in our analysis. Also, the physical therapy protocols among surgeons most likely varied, and the timing and modality of physical therapy for deltoid strengthening cannot be examined. And lastly, we didn't know what the fracture type was, or the fixation construct, or the indication for surgical fixation. And these may all confound our results. Thank you.
Great, thank you, Fabian. And I want to thank all our speakers as well, too. We have a couple minutes for questions, so I encourage people to come up. Maybe while people are coming up, one question for Dr. Freshman. Based on the results of your study, with poor outcomes with delayed treatment of FAI, is there any role, do you believe, for physical therapy or injections for these patients, or should they be going straight to surgery?
There we go. Thank you for that question. I think there's still undoubtedly a role for physical therapy injections. You know, you look at the data, I think it's like 75 to 80% of patients will still get better with non-operative management. But I think the takeaway is that if the non-operative management is not working, don't keep trying it because clearly there's a risk that you're going to have worse outcomes in the end. But yes, non-operative management first, as always.
I have questions for two of you, but I'm going to ask the easier question first. All the lectures are amazing. One was for Edgar, Dr. Garcia Lopez. When you looked at when you were looking at your study, were any of those patients used or treated like we treat using the Mayo study using BMAC, cord decompression plus BMAC? Did anybody have BMAC injected?
Yeah.
And if you did, how did they do? Because we've been beginning to do that at the VA.
Yeah, that's a good question, and I think like similar studies with like a data base, it was pretty limited. We did actually find a couple of patients but the sample size was too small to do any statistics on them. There's also like bone grafting that they did for some of them, but just based on the CPT coding, we couldn't figure out if it was associated with the cord decompression. So we decided to just exclude that. But it's a good thought and something that we're thinking about and are actively including in our discussion for the
It might make a good future study because to try and repeat the Mayo Clinic study, which shows significant improvement with BMAC.
Yeah.
And it was like 53 to 83%. So anyway, just something. Okay,
No,
Ryan.
absolutely. Thank you.
So for Ryan, I have a question about FAI. So when you looked at that study, I know you were looking at the time from diagnosis to treatment. Just historically for the audience, nobody believed FAI existed until just a few years ago, and insurance companies would not pay for FAI surgery until probably 2018. State of Washington would not pay for FAI surgery. California was sooner. So I think another study may be beneficial if you look at the onset of symptoms historically and the delay from onset of symptoms, because there's a lot of patients who are seen who, you know, when we diagnose FAI, they're so grateful that they're not crazy. But anyway, that might make a better study in the future. And I think you have the data that you can do that. And also, historically, this was done with an open surgery. And so that has transitioned to arthroscopic surgery. But I think your study is excellent. And the problem we have with your study is, working at the VA, is that my backlog right now is to December. And so how do we justify to a patient with your study that if my backlog is till December, I'm not going to operate them for 8 months, and from diagnosis and pain is probably been longer. How are we going to deal with that data? You know, for patients who are coming for surgery, and if you publish this, they'll say, well, my outcome's not going to be as good if you're going to delay my surgery. Anyway, all these studies are excellent.
Yeah, thank you, Dr. Sampson. Those are all good points. And I think that is a limitation of our study too. With the Dr. No's papers looking at onset of symptoms to when they actually got surgery, we can't do that with Pearl Diver. We don't have all that data. But what we do have is numbers and the ability to kind of get a little bit better look at the revision surgeries, because of the other papers basically had the revisions. I think they had like maybe 10 or 12 between the papers together. And so they just didn't have the power to actually make those conclusions. But I agree, that's a very difficult thing in a resource-limited setting where you are a single person trying to accomplish a seemingly insurmountable task of taking care of all the veterans properly in a good amount of time. And also there's good data from Northwestern, from Dr. Terry, shows that even in the average layperson, non-veteran, there's a significant delay from symptoms to actual diagnosis and surgery based on all the hoops that people have to jump through with multiple providers, MRIs and whatnot. I don't know if I have a good answer for you, to be honest. But yeah, I think there is also a lot, I think, in FAI and hip arthroscopy of making good patient counseling, and also you know sometimes you are playing a little bit as much of a counselor as you are the surgeon for these patients. So be able to point them in the right direction with those sorts of things. And make sure they're optimized on their non-operative management is kind of a not a perfect solution, but something to think about.
Great. Well, in the interest of staying on time, I wanted to thank all our presentations and speakers from today, both from the first part and the second part. So thank you again, everybody.